So we'll get started with this webinar from the NH Oncology Collegium on immunotherapy. Dr. Shetty was supposed to officially inaugurate it and start it off. He was very keen to kind of say a few words. So if he can, we'll try and get him to join in between. I'd like to now welcome our other two patrons, Dr. Emmanuel Rupert, who's the CEO of the Narayana Health Group, and Dr. Purna Kurkure, who's the chair of the NH Oncology Collegium. I'd like to start by requesting Dr. Rupert to say a few words and followed by Dr. Purna Kurkure.
Good evening, everyone. And on behalf of Narayana Hrudayalaya and the NH Cancer Care, I invite you all for this webinar series on immunotherapy. We are also very glad to have Dr. Mukherjee as part of this webinar. And the cancer care in Narayana has grown tremendously over the last 4 to 5 years. And we have expanded tremendously in this field. And we are also very happy to be partnering with Emmanuel, with the facility being part of the housed in the campus in the Health City. And since we have a very tight schedule and I would not like to take more time, I think Sharat, you can just say it.
Yeah, thank you, Dr. Rupert. If we can have a few words from Dr. Purna Kurkure, ma'am.
Good evening and welcome to this very interesting webinar which we are having now, that is on immunotherapy in cancer. And this webinar series, we have, can you hear me? All of you?
Yes.
This webinar series was an inspiration during the lockdown period in pandemic, and it is being further continued, and I'm very glad. It binds all the units and the oncologist like a chain, and we interact on a very regular basis on various academic topics. And today we have a discussion on immunotherapy, and we are very glad that Dr. Siddhartha Mukherjee has been able to join us, and also to be followed by our own. We try to see that our own faculty gets involved in these webinars and bring out the best. And there will be a good deliberation on the same subjects by our faculty. And I congratulate Dr. Damodar to arrange for this very interesting webinar. Over to you, Dr. Damodar.
Yeah. Thank you, ma'am. So we won't waste any more time. We'll get started. It's a pleasure for me to introduce Dr. Siddhartha Mukherjee, who's a Padma Shri. He's also currently the Associate Professor of Medicine at Columbia University. And we all know him from that lovely book which he's written, The Emperor of All Maladies. It's become extremely popular among the medical fraternity. So it gives me a great pleasure to introduce Dr. Siddhartha Mukherjee and ask him to start his talk. We've got more than 150 people who are registered. So there's a lot of interest in CAR-T in India. So clearly you have a really good audience, Dr. Siddhartha.
Thank you very much. I will be focusing for the next half an hour or so on immunotherapies, and of course, with a particular interest in CAR-Ts. I'll tell you a little bit about what we are doing in the CAR-T space and how we are bringing these novel therapies to India. Let me begin by introducing the company that I co-founded with Kiran Mazumdar-Shaw and Kush Parmar. Our vision was to see if we could really create a ecology that would support the delivery of CAR-T therapies in India, and that's been our goal from the very first day, and that's been what is driving the vision of this. Arun Anand was trained in India, then did his postdoctoral work, and is now the chief operating officer and the CEO of Immunil, and he's of course joining us today. And thank you, Arun, for your help. We created a scientific advisory board, which is, I would say, unrivaled in its capabilities. Bruce Levine and Carl June, as you may very well know, were among the first to deliver CAR T therapies in the world. Carl and Bruce developed the protocols for the delivery of CAR T therapy at UPenn. Bruce really is also a professor, but really helped in the manufacture process of the CAR Ts and the storage of CAR Ts. And these were against CD19, the antigen that's found in B cells. And the first patients, as you may remember, were treated for relapsed refractory B acute lymphoblastic leukemia, or BALL. Dr. Nupur Raje trained in India, then it trained with me actually at MGH, is now a group leader and a professor at Harvard. She ran the first BCMA trial, the pivotal trial for multiple myeloma using CAR Ts, and is running now several other trials with CAR Ts at MGH. And Dr. Vijay Chiruvolu, who has been a member of several advisory boards, but is really someone who has been brought on to advise us on process development and how to keep CAR Ts stored safe and cheap, but most importantly, effective against cancers. The purpose of all of this, again, remember, a CAR T cell, when we'll come back to this, a CAR T cell is a cell that has been weaponized using, it's a T cell from your own body that we withdraw from the patient. So it's an autologous product as of now. It's withdrawn from your body, separated, essentially blood is withdrawn from the body, separated out into its various fractions. The other fractions which are dispensed, and then the T cells are taken into account. They have to be equipped with a gene that allows them to recognize the cancer cells. So they are equipped with they're weaponized, as we say, with the gene to recognize something on the surface of a cancer cell. And they also have the capacity through that same weaponized gene to become highly activated and remain in your body to guard against or stand guard against that same cancer. Even after the cancer is dead, the T cells enter memory, become memory T cells, and those memory T cells have the capacity, should the cancer rise again, those memory T cells will renew their attack. And of course, a big question is how to handle, how to deliver the genes into those T cells, how to collect and harvest and store those T cells, and of course, the safety of these T cells, because these therapies can not only kill the cancer cells, but also kill normal cells. And when they do that, they create a very active inflammatory response. And one of the big concerns with T cell therapy is we need a whole infrastructure around that response. So really, I would say that there are two kinds of infrastructure, broadly speaking, in order to deliver CAR T cells. One of them, of course, is the one I'll focus on, which is driven by our company, Immunil. And that is how to make these weaponized T cells from individual patients with cancer. The second one is also the infrastructure, which is required around how to deliver these T cells in a manner that is safe and effective to patients. And really there, the best infrastructure there is a bone marrow transplantation ward. It is, in this case, being used for cellular therapy, but it's really a bone marrow transplantation unit that can support the cellular therapy. So I'll talk about the company itself. We have sort of three pillars of infrastructure. The science, so we have very powerful science. Often we are able to do two things. One is to bring in licensed products such as CAR Ts against CD19, which would be active in in lymphomas and in B-cell leukemias, or CAR Ts against BCMA, which would be active in multiple myeloma, which is, as you know, a disease quite prevalent in India. So we're as well as we're developing our own Immunil-born CAR Ts, which are new to the world. and we're in the process of developing those. Those would be products that we make for the first time and use for the first time. There's a question of, we've gathered at the team. I've introduced you to a little bit of the team. That's just the top surface. I know that Dr. Kamath is here. I already introduced Dr. Anand. And then the infrastructure. The infrastructure is enormous because these cells have to be produced and expanded in a facility that is safe, clean, and GMP certified, which means that it has to have basically run through a whole number of checks to ensure that there is no contamination of the cells. They also have to be, as I said, they have to be weaponized. And in order to weaponize, we have to perform gene therapy on these cells. That gene therapy is performed by delivering a lentivirus to these cells. And the lentivirus is a virus that enters the cells and doesn't replicate, but once it enters the cells, it carries with it as a payload, it carries that gene that I was describing, the gene that will allow these cells to kill the cancer cells and become activated, the T cells. Our real advantage here was to really focus in on cost. Just to give you some examples, the typical cost of CAR T cell products, commercial products in the United States, is about $400,000. And obviously that is unaffordable for the Indian market. We are hoping to bring that cost down radically. Of course, the numbers are still being managed. Some of it has to do with creating a very smart infrastructure and creating our homemade systems and homemade innovations to bring the cost down. And how we can bring those costs down is very important. Now, just to remind everyone, if you look at the top right-hand corner of the chart, you'll see that much of that cost, 57% of that cost, is in consumables, which means hardware and tissue culture and reagents and so forth. So those costs we are extraordinarily conscious of. We are in the middle of either producing or making the systems using innovation within the company to making those systems not dependent on so many consumables that are expensive and have to be dispensed of, and that we bring down the cost enormously. And of course, labor, shipping, and overheads are radically reduced in India. So there is a lower floor, I would say, to the cost. We cannot go beyond a certain floor because of the nature of the therapy. These are products that are extraordinarily complex to make. But nonetheless, through a number of collaborations with Syngene, with Clinic Barcelona, and with the University of Pennsylvania, we are slowly learning to create what we call a manageable ecosystem with Indian-made adaptable technologies, such that we can bring the cost down to a level which will be dramatically lower. We are still deciding what that number is going to be, but will be dramatically lower in the Indian population. Now, this is not cheap therapy. However, this is not however you do it. Given the costs of labor, of the consumables, such as the virus and the facility which we have now built out, there will always be a floor to this cost. This is not going to be available without, it's not sustainable. But what, as I said, using an enormous amount of innovation that has gone on in the Immunotherapy labs, we will be able to deliver these therapies to Indian patients. This is the lab itself, and it shows you sort of some of the complexity of the system. It was inaugurated, the infrastructure, by Dr. Renu Swaroop virtually. And here is Dr. Shetty, Dr. Shaw, and Dr. Anand inaugurating the facility. This is a sort of a quick view of the facility, but just to give you the sense of the complexity of it. These are machines. This is obviously a tissue culture hood. These are machines that allow us to extract the T cells using various technologies. Once the T cells are extracted, as I said, they are weaponized. using the lentivirus system. Then they have to be expanded for a few days in incubators. And again, we have to ensure that the batch of T cells is appropriately expanded, is not contaminated with anything, and then ultimately released to patients. And there are a whole bunch of criteria. And the broad team that you will see in a second, the broad team is really divided up based on these. Some people are focused on the creation of the physical infrastructure, which you see here. Some people, of course, are focused on procurement and the management of all these very complex machines. Others are managing and running these complex machines. And then we have yet another team that is entirely focused on what we call QC and release, which is to ensure that the product that comes out meets the criteria, meets the highest criteria, the criteria that are used in Europe and the United States for the release of the product. I'll talk a little bit about, we have our own indications that we are working on. So we also have one part of this team is actually a research part of the team. This is a new field, and it's being born as we speak. And so we have one part of the team that is dedicated to discovery. So we will find and have already found our own targets unique to Immunil. We are making CAR-Ts that are unique to Immunil against multiple myeloma and lymphomas. And these will be products that we should be particularly proud of, because they're entirely homegrown from the company itself. And so those will then go into the regulatory process the regulatory process for Indian regulatory boards. And at the same time, in parallel, we will continue to figure out how to manufacture them. And then finally, the final piece of this is the delivery. And as I told you, we are interested in making that delivery possible initially through the connection between, very intimate connection between Immunil and NH. And as you know, several members of the NH bone marrow transplantation team, both the adult and the pediatric bone marrow transplantation team, have been very close collaborators. And I would particularly like to acknowledge them as our close collaborators as we move forward. Dr. Damodar and Dr. Sunil have been extremely close collaborators during this process, and will continue to do so as we move forward. One second. We just to remind us that that this is not something that you can just wake up one morning and make, and it is not a pill. It's not it's not even a biologic. So I'd like to remind people that a clean room is not enough to do this. You need a GMP, and as you very well know, the GMP is much deeper than a clean room. You need advanced analytics, quality training, quality control. Sorry. And we have, I would say, heroically, in the months of COVID, been able to create this ecology within Immunil itself, and Immunil is, of course, very closely attached to NH. So I would like to extend a particular congratulations to the team because of its capacity to be able to do this during a time which was very challenging for all of us, but to be able to get a GMP facility up in India, in Bangalore, during the middle of COVID, with all the appropriate stakeholders, such that we could send a dossier to the regulatory authorities, which would rival a dossier that would be sent in any other country in the world, is of course a very impressive thing. It is one important feature of all of this is that one of the innovations that was introduced early on, which we also think is very important, is in the US. Currently, the CAR-T products are being manufactured in central facilities, and then being shipped out basically frozen and shipped out. So a patient's T cells or blood is collected, and then that product is sent over to a central factory, for instance, one of Novartis or Kite's factories, and the factory then produces the CAR T. Remember, it's an autologous product, so it can only be given back to the person from where it came or from whom it came. So it has to be shipped back after quality control. We realized that these infrastructures were not the shipping and the management of those infrastructures may not be up to par or up to the level that we wanted to in India. So we decided instead that rather than sort of bring the hospitals to Immunil, we would bring Immunil to the hospitals. And that is how this relationship with NH began. And we have placed ourselves really next to the BMT facility to access the clinical infrastructure in our first phases. Whether we mature and become more of a pod for other places remains an open question. But this innovation was very crucial because it allows us to interact with the bone marrow team very effectively. Sorry. And of course, we are focused on affordability. So just to remind us, all this ecology from our own research novelty to affordability is going to happen, and it's happening already within Immunil itself. Again, to emphasize what we have achieved and I would say the enormity of what we have achieved. I won't focus on every piece of this system, but this is the Immunil, basically the center where we are manufacturing the T cells. It's 12,000 square feet, has the capacity to expand. Most importantly, it has 3 separate cell therapy suites, fully equipped quality control lab, and of course a separate R&D lab, which for making our own assets and innovate those processes. We stick to the strictest standards. So based on international guidelines, we are compliant with all the waste and other forms of quality control that ensure the safety of the workers in this environment, and of course that safety extends out to both training of all the people who are working in the facility, as well as constant mitigation of risk and engineering to ensure that this remains a working facility for very sick patients. And we are based on national guidelines. We have, you've gone through some of this already, but one piece that I have to emphasize over here is that we are also building in data integrity and traceability. Obviously, as I said, this is a product that requires multiple data steps. Have a patient's T cells adequate? Is there a proper control on that? Has the viral infection been adequate? Is there a proper control on that? Obviously, it would be a disaster if we gave the wrong patient the wrong dose or the wrong cells, because this is a product that's made for, it's deeply personalized. It's an autologous product. So all of this is managed now using digital traceability, such that, as I said, it conforms to the standards that are used internationally and have been used, for instance, at UPenn, Stanford, Columbia, and other places for the delivery of CAR T cells. Just to give you a sense of what the unmet need here is, and it keeps expanding because the field keeps expanding. Here is data from several studies where you have in what I would call the pre-CAR T world. On the far left, this is from 2007. The prognosis of patients with children, mostly children, but a mixture of children and adults with B-cell ALL, or acute lymphoblastic leukemia. And these are survival curves. You may be familiar with them. And you can see how deadly the disease is if you have a first relapse. Virtually all the patients die, unfortunately. It is particularly deadly as you get older. Slightly younger patients have about, a 5-year survival of about 20-odd%. If you're in the 35 to 45 age group, which is a smaller fraction, but if you're in that age group, then you unfortunately have a 5-year survival of about 4%, which tells you how deadly that disease is. Similar, so that's with acute lymphoblastic leukemia, and of course, this on the right side is using the gold standard therapy for non-Hodgkin's lymphoma, which is R-CHOP. This is from the Lancet in 2013, and again you see that 25% of the 25% of the patients will have a poor prognosis, and I would say if you go out to 7 to 8 years, you begin to get down to the high 60% ranges, even with the standard therapy. Now, there are some particularly bad forms. Non-Hodgkin's lymphoma comes in many different forms. This is the diffuse large B-cell lymphoma, DLBCL, which is the one that's actually quite responsive to chemotherapy. There are other non-Hodgkin's lymphomas that are extremely unresponsive to chemotherapy. And so if you have refractory large B-cell lymphoma, in other words, if you don't have a response in this situation, your overall survival again plummets dramatically to the 20% range. So there are tens of thousands of patients who would be eligible for treatment for non-Hodgkin's lymphoma, and I would say thousands of patients who would be eligible with relapsed ALL for treatment with CAR-T therapy. This shows you what CAR-T has done to this incredible world or ecosystem. I'll just focus, for instance, on the bottom study. This is patients this is the so-called Juliet study, recently published. These patients did not need to have transplantation, and in fact, 50% of patients remained in a complete remission or remission, and the overall survival not yet reached, because this line flattens out at about 50%. So this is obviously a dramatic change in the ecosystem, as it were, of CAR-T therapy. Here on the top, you see again another study, so-called Ileana study, and here the number of patients that remained in the overall survival at 34 months was 60 to 70, between 60 to 70%. So again, very impressive data, and this keeps evolving as we make new CAR-Ts, combine CAR-Ts, and liaise in with the research program that, of course, we have initiated. I've already given you an overview of what exactly CAR-Ts are, but just to remind you again, you extract the T cells from the patient's body. I'll start from here. Here is a patient, let's say with ALL or lymphoma. You extract the patients from the body. You use a virus to deliver into the T cells. So you purify the T cells. You use a virus to introduce into the T cells this weaponized piece. This is a receptor or a piece of an antibody which will recognize the tumor as a foreign object. And then these T cells then multiply. They are grown in the laboratory. They are tested and released. And then with a little bit of chemotherapy, and I say little bit because this is just to make the T cells engraft into the patient's body. They are then infused back into the patient, and that is the process by which CAR-T is made. The first one, a commercial product, was available in 2017. That was called Kymriah, followed very quickly by Yescarta, and now followed more recently by Tecartus. And again, these are indicated in ALL, diffuse large B-cell lymphoma, and in the case of Tecartus for mantle cell lymphoma. And all of these have been transformative products. But of course, as I told you, the price tag has also been transformative in the sense that they are, in the United States at least, Kymriah and Yescarta come with a price tag of about $400,000, $350,000 to $400,000, and that seems to not have moved at all. These are now multi-billion-dollar companies that are making them. But unlike Immunil, as I said, we have created a whole chain of innovations to make this available. These are some estimates of what the unmet need would be in India, and I think these are lower-end estimates because many patients are not reported. But the unmet need in India annually would be 4,400 ALL patients and 12,000 non-Hodgkin's lymphoma patients. Now, as we move along in this ecosystem and understand where the role of the CAR-T is, we may well find that these numbers actually double, because many patients we would rather treat them upfront with a CAR-T therapy rather than in the relapse refractory setting. I should emphasize that that's actually a huge advantage that Immunil gives us. If we could bring the costs of therapy down to a more reasonable range, then we could do a pioneering kind of central study in India, which would not be achievable elsewhere, in which we give these products upfront rather than toxic chemotherapy for patients whose genetics indicate that they are unlikely to respond to therapy. So multiple myeloma is a very good example. The trouble with multiple myeloma is that by the time the BCMA CAR-T is being used, most of these patients have gone through multiple rounds, sometimes 4, 5, 6 rounds of chemotherapy, and then relapsed and relapsed again and relapsed again. And by that time, obviously, the chances of yet another therapy working becomes diminishingly low. If we could create products, and particularly products that are of local origin and are of much more reasonable cost, they avoid potentially all of these multiple relapses and maintain a longer remission in the first phase of the disease. And you can imagine that, in fact, the savings are ultimately greater. Not only the savings, not only the toxicity of this, but also the financial toxicity of going through multiple rounds of various chemotherapies, potentially transplantation, et cetera, all of which add up to an enormous amount of financial toxicity, as opposed to being able to give these upfront. The Eliana study I already spoke about. The Juliet study I already spoke about. The mechanism of action I want to finish with, and then we can have time for some questions. So I already spoke about how this is achieved, and at every step I should emphasize that we are making our own innovation. So CAR T cell, in this case a CD8 positive CAR T cell, meets the tumor cell and recognizes, using its receptor, it recognizes the antigen on the tumor cell. It then proliferates and then also delivers a signal to the tumor cell, also delivers a signal to the helper T cell. And these together ultimately kill the tumor cell. So there is much to be done here, much to be learned about how to deliver these products. But I would say that we have created a very unique ecosystem at Immunil, and are looking forward to making our own products, not only our own products that we have in-licensed and that have already been clinically exposed, such as CD19 and BCMA, but in fact, we have actively created a research program that will create our own never before CAR-T products that we will bring into trial through the appropriate regulatory authorities in India. And this is I would say, a great moment of personal pride for all of us and for me to be able to bring such kinds of therapies to the Indian ecosystem. So I'll stop here, and if anyone has any questions, please either put them on chat or maybe Dr. Damodar will coordinate the questions.
Thank you, Siddhartha, for giving us a lovely overview on CAR-T therapies and the fact that realistically we have things happening here in our country with a plan to actually deliver this to some of our subset of patients, and clearly with an intent to also cut cost and certainly make it more affordable to our population. There are a few questions in the chat box. I think some of the panelists can also ask the questions directly. I'll start with the question from Vivek. So there's a lot of heterogeneity among the different CARs, specifically with respect to the CRS. So how is Immunil different from others, and how do you ensure that CRS is less?
So, the phenomenon, first of all, for people who may not know this, CRS is cytokine release syndrome. It is a syndrome that occurs when the T cells become active and when they create an inflammatory milieu or an inflammatory disorder, and they start secreting cytokines that can be quite dangerous, because these cytokines, the body thinks that it's under attack, under a terrible inflammation, and in fact, the failure of the first CAR-Ts was because of this CRS syndrome. Many patients died because this syndrome was a problem. And one of the crucial innovations by Dr. Carl June, who's on our board, was to realize that certain drugs, including drugs that prevent certain block the activity of certain cytokines, can be used to modulate the CRS. There are several things that we are doing in collaboration with Penn and with others to diminish the CRS syndrome. One important feature is to fractionate the delivery of the CAR-Ts. So not to deliver all the T cells in one big glut, as it were, but to really deliver them in fractions, and figuring what fraction for which CAR-T is part of the clinical protocol, and this is where the art of medicine is very important. Secondly, we have access to drugs that block CRS. These have been made in India and are available in India, and so there is that. And finally, on a research end, we are looking at how various activation domains can be tuned, and we have potential research collaborations with various collaborators who are trying to make CAR-Ts more tunable, and by tunable I mean they can be more or less activated depending upon the cancer itself. So those are just three of the innovations that allow us to mediate or modulate CRS, and there are more that are coming.
Is there any other different protocol for the lymphodepletion which is to be used?
There are multiple protocols for lymphodepletion, but we will follow the standard protocol for the product that we obtain. Of course, when we have our own products, we will create our own lymphodepletion mechanisms that we will use.
So there's CNS disease, either in ALL or maybe in a lymphoma. With the blood-brain barrier there, is there an issue of the utility of CAR-T, or would you kind of avoid that when there's CNS disease?
So it's a very important question. It's been explored. It is currently being explored in studies here. For CNS ALL, we are still giving CNS prophylaxis. For overt CNS ALL, we are not using CAR-Ts at present. There is a reason to believe from our lab and from Carl June's lab that in fact these T cells do cross the blood-brain barrier and are able to recognize cells that are in the CNS. But really, that is really an ALL specific question to some extent. Most of the other diseases, Hodgkin's lymphoma and multiple myeloma, are not CNS penetrant diseases until their late phase. I'll also add that in the CNS disease is manifest if we usually, again, one of the crucial innovations that Immunil allows us to do is to stratify patients up front. This upfront is very important because we can thereby do this before patients are treated through multiple rounds of chemotherapy. And upfront treatment of CAR-Ts is a very radical idea. It cannot be applied in the United States for for the most part because of the cost of these therapies. If all of these people went through upfront CAR T therapy, we would basically break the bank, as it were. But in India, with a more affordable product, we could actually try this, and that would be a great, I would say, that would be a great gift back to the medical community of the world, because we would then understand how these therapies could be delivered upfront rather than other forms of chemotherapy.
Right. Maybe I'll squeeze in one more question. The CD123 CAR, is that available, and what's its utility? Siddhartha?
The CD123 CAR is a CAR against myeloid cells. Myeloid cells express CD123. It is under investigation in the multiple trials in the United States. It has some fundamental questions that surround it, because one big question is, how do you avoid the toxicity to normal myeloid cells? So we are watching very carefully to see the extent to which the CD123 CAR will be successful in removing not just the myeloid leukemia cells, but also figuring out how to manage the toxicity, which would be an on-target toxicity on normal myeloid cells. And you cannot live without your normal myeloid cells, the cells that form your bone marrow, etc. So these trials are in progress, and we are awaiting to see how this might play out. The most promising of these trials, I would say, uses CD123 and then follows it up with an allogeneic bone marrow transplant. And so really CD123 by itself won't work. You will need, because it's a bridge to a bone marrow transplantation. And those are the trials that are being performed. So we're eagerly awaiting to see what the results of those trials look like.
Okay, maybe I'll give you one more. Your views on oncolytic virotherapy just popped up.
Well, so, this is not a central focus of Immunil. Oncolytic viral therapy involves delivering viruses that kill cancer cells directly, and have been successful or partially successful in early trials in places that are very difficult to access, such as the brain. So for glioblastoma multiforme and so forth. And again, we, it's a real, it's in mid-trial, I would say, but that will not be a focus of Immunil. We are not going to focus on oncolytic viruses in the first instance.
Right. Thank you so much. I think we're done with most of the questions. We've got still another half of the program to go. Thank you, Siddhartha, so much for your time and your inputs. We will see.
And looking forward to bringing this product to very desperately ill patients in India, and I hope we have everyone's collaboration, because that is the way to success. Thank you very much.
Right. Thank you so much. Thank you so much.
Right. Thank you, sir.
Right. We'll go on to our second part of the program from our speakers. I'd like to start with immunotherapy in acute lymphatic leukemia. It's my pleasure to welcome Dr. Sunil Bhat, who's Director and Clinical Lead of Pediatric Hematology and Oncology and Bone Marrow Transplant at the Mazumdar Shaw Medical Center. Sunil, welcome and start your talk.
So good evening, everyone. And I think we should all pack up now. We are done. And Siddhartha has, conveyed what what was the gist of this meeting. So it's very difficult to follow him. I think, we all know he's a great speaker and, puts everything into great perspective. So I'm basically going to be kind of touching upon the immunotherapy in ALL, but I will not be discussing the CAR T therapy at all, because I think that we have just heard in the previous session already. So in pediatric ALL, basically, it has been the success story of oncology, and especially pediatric oncology. What was maybe less than 10%, a few decades ago, is 90%, more than 90% curable, especially in the West and some of the state-of-the-art centers in the world. It's a very very I think familiar slide to all of us, which kind of shows how the response rates or the cure rates have improved over the period of time. So what was the universally fatal disease in 1960s, and if you see the recent data from St. Jude's, around 93-94% cure rate. So that's how the treatment in ALL, in pediatric ALL, has emerged, and that's kind of the experience from other groups as well. And this is some of the data from COG. But we know that ALL is a heterogeneous disease, not a disease, with uniform outcomes all through. And we do have some bad players. If you see here, where the cure rate still in this current era is in the range of 30-40%, and then we have the very good players where the cure rates are above 90-odd%. But what has what has emerged as a central point of all these is the treatment response, how the leukemia responds to the treatment. And that treatment response not only kind of is dictated by the type of leukemia we're dealing with, but also probably the microenvironment and the host factors, and of course the therapy which is delivered to these patients for getting the treatment response. And as the most important parameter in the current age to determine the treatment response has been the minimal residual disease. And the better and the deeper remission rates are there, the better are the outcomes. And this is just a cartoon to showing that how deceiving the remission status can be, especially in ALL. Although you may be seeing a complete remission on morphology, but how the minimal residual disease can vary in these patients. And that, of course, that is important because that leads to our prognostication and also the chances of long-term remission as well as long-term cure. Patients who are MRD negative do really well as compared to one where the MRD is reasonably high. So this is important measure of this outcome treatment response in these patients. A word about relapsed ALL, because relapsed ALL is the fourth common cause of childhood cancer, and even though relapses in children are less, but still it is the fourth most common cause of cancer. And if we see at the relapsed ALLs, although this is the data from various groups, and even though you treat them again, but the outcomes next time when you treat them are not as good. So it can range from 20 to 40, 50-odd%, even in the best of the centers. And if we have a subsequent relapse, the outcomes are even worse. So that kind of opens up, a subgroup of patients in pediatric ALL, wherein you need to have some innovations. You need to have out-of-the-box treatments, and there are a few of them which have been tried in various subgroups. Whether it's a PH-ALL or it's TKI post-transplant in the PH-positive ALLs. Infant ALL is kind of dealt differently. The T cell, ETP ALL has been dealt differently. Now, this again opens a window for what immunotherapy was, which is the theme of today's meeting. And where what we do here is we either use cellular or humoral components immune system to target the leukemia cells, and those can be monoclonal antibodies, conjugated antibodies. I'll touch on this a little bit in great detail later. Adoptive T cell therapy, which was just discussed, which can be T cells or NK cells, modified or unmodified. Cancer vaccines, which was, there's a question about that in the chat box. And of course, hematopoietic stem cell transplantation itself is a type of immunotherapy which can be delivered to these patients with ALL. Now, the immunotherapy has advanced, and it's nothing new, but it has kind of evolved over a period of time. Autologous transplant followed by allogenic transplant. These were the earlier forms of immunotherapy kind of delivered to leukemia patients, and then followed by donor lymphocyte infusion and other post-transplant strategies, the patients who underwent transplants. But more recently is the era of antibodies, both conjugated and unconjugated, and also the checkpoint inhibitors and the CAR T therapy. So this is how the progress in this field has happened over a period of time. Now, what basically in these immunotherapies you either target the tumor directly, which can be with direct antibodies or chemotherapy. It can target the host and modulate the host response to the leukemia, or it can be targeting both the host as well as the tumor, and that's the more successful way of delivering chemotherapy. And we have examples of that, which is CAR T, blinatumomab, allogenic stem cell transplantation, where you target both the tumor as well as the host and utilize the host in fighting back the leukemia and the tumor. So what are the potential targets on the B cell in ALL patients? So these are potential targets showed in the arrow. There are many more which are being studied, but these are the ones which are traditionally being used as the B cell target, and the most important ones being the CD19 and the CD22. Now, how do these antibodies act on these B cells? So, there is basically, a combination of complement-mediated activation. There can be antibody-based cellular toxicity, and what all of these do is that they lead to apoptosis and cell death, as a consequence of the antibody actions. Now, what can be done, to these antibodies to make them more effective? And there will be a few strategies which have been adopted to make them more effective. One is humanization. Humanization, is to reduce the antigenicity to these antibodies. And the best example is rituximab, which is a chimeric antibody against CD20 and is humanized. Empanotuzumab is also humanized. We can also increase the binding affinity of these antibodies, and we can also conjugate these antibodies to either to chemotherapy or to toxins or to radioisotopes for better action. And we had also have bispecific antibodies which can bind to different components of the immune system and not only to the cancer cells. And the examples of unconjugated antibodies are empanotuzumab, where these are humanized antibodies, but there's nothing additionally conjugated with them. Anti-CD22, we have alemtuzumab, we have rituximab, which are the different targets on the B cells. Now, when we talk about the conjugated antibodies, the best example of that is inotuzumab. This is a anti-CD22 where you have calciumycin, which is bound to this anti-CD2, and there are some others which are being trialed at the moment. Now, how does this work basically? So this is inotuzumab. When it binds to the surface, CD22 on the surface of the cells, it's internalized, and when it's internalized, it releases this conjugate, which is released in intracellularly and goes and breaks the DNA and leads to cell apoptosis. So a very effective way of killing these cells which express CD22. Blinatumomab, on the other hand, is a bispecific antibody, which we know that it binds to the tumor cells on one side, which is the anti-CD19 antibody component, and then it also binds to the anti-CD3 component, which is the T cell component to it, and then it mobilizes the host T cells, and those host T cells go and attack the leukemia cells, leading to cell death and cell lysis. Now, what are the experience with these products? Or what are the experience with blinatumomab? This was the earlier data which was published in JCO, wherein they studied phase 1, phase 2 studies on relapsed and refractory ALLs, and the marrow blasts were more than 25%, and they used blinatumomab continuously for 4 weeks. And even this very highly, high risk group, which is relapsed and refractory, about 40% of the patients had complete remission after one cycle, and you can see that over 50% of the patients had MRD negativity after one cycle, which is a great response in this very difficult patient group. Now, there have been studies, phase 3 studies in the patients who are MRD positive. I think that one of the strongest indications for using blinatumomab in pediatric ALL is the patients who are MRD positive, and you can really convert them to MRD negative after giving blinatumomab. The another advantage is the patients who may not be fit or suitable for chemotherapy because of fungal infections or bacterial infection underlying. This is the area where you can apply these, because the risk of infections and neutropenias are almost negligible. And it's also a bridge for these patients when they are MRD positive, convert them to MRD negative, and offer allogeneic transplant after MRD negativity has been achieved. Now, this is just data, a small patient numbers though, but this is the data where they used in MRD positive patients blinatumomab to get into MRD negative status, and then transplant after that. And if you see, the event-free survival and the overall survival of these patients post-transplant, it's quite reasonable. And these were all heavily treated refractory group of patients. Now, coming on to inotuzumab, the other conjugate antibody, which we discussed in the previous slide. What's the data on that? This is the largest series of inotuzumab with 51 odd patients, which was used in a compassionate use program, again relapsed refractory patients. But even in this high risk group, around 60 to 70% of the patients had CR in just one cycle of inotuzumab, and 70% were MRD negative. We have to remember that transaminitis and VOD post-transplant are important complications with inotuzumab that needs to be kept in mind, especially in the group of patients where you offer transplant post-inotuzumab therapy. Now, CAR-T, we just heard, we saw this cartoon. Now, what are the differences between blinatumomab and CAR-T? This is a question is commonly asked. CAR-Ts, we know it's a one shot treatment, one-time infusion, and then they persist for weeks, months, and years post that. However, it takes 2 to 4 weeks for the manufacturing. Blinatumomab is often a prolonged continuous infusion. It may take several months. It's off-shelf product. It doesn't need to be manufactured for the patient themselves. CAR-T has probably a little bit more experience now. There are a lot of trials which have been completed. Blinatumomab also, I think, we have got sufficient data now. But if you look at the response rates, CAR-Ts are offering probably a little better response rates, which may not be sustained, unfortunately, in all the patients, but definitely is better than the Blinatumomab, and their toxicities are quite different. We heard about CRS, which is quite significant CAR-T therapies. It can happen with Blinatumomab also, but that is probably little less and manageable. Now, I think Siddhartha touched upon CAR-T therapy as frontline therapies, and there is some thought process and some studies being done on this in the zone of antibodies as well. And there are a couple of studies which are run in the North America, where in the Ph negative adult ALLs, Blinatumomab or inotuzumab is added with mini CVAD, and this is usually for older elderly patients where they may not be able to tolerate the full blown chemotherapy. There's also adult study where Ph positive ALLs where they are using dasatinib with Blinatumomab as frontline therapy. In pediatrics, there are again few studies where there's for example Blin plus chemo used versus standard chemotherapy in standard risk ALLs in COG studies. There's also randomization of inotuzumab plus chemo versus chemo in high risk ALLs. In BFM, they're studying Blin randomization intermediate and high risk ALL, and St. Jude's again is offering Blinatumomab upfront in the patients who are MRD positive after after induction. So there's exciting times now. These treatments are being offered upfront in frontline. This is one of the papers which recently came. I think we all have seen this dasatinib and Blinatumomab for Ph positive ALLs, and this was a great data of no chemotherapy, no just targeted therapy with these two targeted agents, and it was really a thought-provoking paper. So to summarize, I know we don't have enough time to summarize that pediatric ALL's treatment outcomes improved really in the last few decades. It's really a true success story. What has led to that is risk adapted therapy, targeted drugs, better supportive care, but immunotherapy is emerging in a big way. Monoclonal antibodies, both Blin and inotuzumab, have promising activity in relapsed refractory as well as in MRD positive disease, and can be offered with very minimal and acceptable toxicities. CAR-T therapy for refractory disease has brought in a paradigm shift, and slowly immunotherapy is finding its way in upfront treatments, and there may be a time that we may treat these patients without chemotherapy with one of these immunotherapy agents, which is going to be targeted. So thank you very much for your attention, and I hope that I've stuck to the time. Thank you very much.
Thank you, Sunil, for giving us a nice, crisp and clear talk on immunotherapy in ALL. I think we'll finish the next two talks and then take up some questions because there are a few popping up. We'll go on to our next speaker, who's Dr. Vivek Agarwala. He's a senior consultant medical oncologist at Narayana Health in Howrah in West Bengal. Dr. Vivek, your topic of immunotherapy in lymphoma.
Yeah. I hope I'm well audible and the slides are visible. I thank you, Dr. Sharat, for giving me this opportunity, and it was really an enjoyable experience listening to Dr. Siddhartha. So I have been given this rather tough task of giving an overview on immunotherapy in lymphoma in the next 10 minutes. I'll straight away start. So let us first go into some of the basics of immunotherapy in a nutshell. So the immunotherapy, can be different as per the mode of immune action. So it can be antibody mediated or a T cell mediated, NK cell mediated, phagocyte mediated, or an artificial intelligent, designer cell mediated. And it can also be different as per the modes of application. So it can be given either by transferring of certain immune effectors into the body, that is the adaptive immunity, or by vaccines, or by activation of certain endogenous immune effectors, that is the T cell activation by the immune checkpoints. So let us consider this is a tumor cell, and this tumor cell has certain cancer antigens, which are of course expressed on the tumor cell as well as secreted, and these cancer cells also has loss of the MHC molecule. So therefore they are immunogenic, and the antigen presenting cells, which are the macrophages and the dendritic cells, they really catch these tumor antigens, recognize them, and once they recognize them, these cells, they link up to the T cells. The antigen is presented to the T cell via the T cell receptor. there is a positive interaction between the receptors and secretion of cytokines by the T cell, which further recruits the T cells in a positive manner. And this T cell is now immune, and it is directed towards the tumor cell to kill the tumor cell. Now, the tumor cell does develop certain negative signals like the PD-L1, which is expressed on the tumor cell, which acts against, interacts with the PD-1 on the T cell, inhibiting the T cell and giving a signal of don't kill. So this is how, the body evades the immune system, and we can harness this by either enhancing the enhancers, that is by, improving our innate immunity, or by inhibiting the inhibitors by, interfacing this interaction between PD-L1 and PD-1 with certain monoclonal antibodies. So this is how we can improve the T cell mediated killing. Now, the antibody mediated killing is classically by the antibody dependent cellular cytotoxicity, antibody dependent cellular phagocytosis, antibody dependent direct toxicity, and the complement dependent cytotoxicity. And this is classically by the antibodies, monoclonal antibodies against the tumor surface receptors. The classical example is rituximab, which is an age-old chemoimmunotherapy, first-line treatment for all B-cell lymphomas. And then there can be certain artificial designer cells. So, for example, is the bispecific T cell. So, this T cell, this antibody engages the CD3 receptor on the T cell as well as the CD19 on the tumor cell, thereby linking the T cell directly to the tumor cell. And then there can be artificial designer CAR T cell, which we just heard about. And then this is a very interesting newly immune mechanism of activating the macrophages to kill the cells. So the tumor cells again interact with the SIRP alpha, which is there on the macrophages, to inhibit being recognized by the macrophages and by decreasing the antigen presentation. And then this interaction can also be blocked by antibodies, thereby giving the signal to the macrophages to kill the tumor cells. So this is also something which is there. So coming back to lymphoma, so lymphoma is definitely a unique subset for immunotherapy because it is a malignancy of the immune system itself. And here the malignant cell easily orchestrates the mechanisms to evade immune system. So there is limitation of antigen presentation, there is loss of MHC1, MHC2 molecules, there is interaction with the SIRP alpha, there is LAG3, then there are increased co-inhibitory signal pathways. So we see TIM3 being activated in follicular lymphomas, PD-L1-2 activated, more expressed in Hodgkin lymphomas. There are also increased secretion of immunosuppressive cytokines like transforming growth factor beta, interleukin 2, interleukin 10. And also the tumor microenvironment is sometimes resistant, recruiting the inhibitory cells, the Tregs and the suppressor T cells. And these are the various mechanisms in a nutshell how we can harness each of these steps to deliver immunotherapy in lymphoma. So if you give an overview of immunotherapy in lymphoma, so we have monoclonal antibodies. We have the antibody drug conjugates, brentuximab and polatuzumab. We have the bispecific monoclonal antibodies, blinatumomab in CD19, mosunetuzumab for CD20. Then we have the T cell checkpoint controls, that is the immune checkpoint inhibitors. Then we have the innate immunity checkpoint control, which I talked about, activating the macrophages, the recently tried magrolimab. And then we have CAR T cells, and then we have the allogeneic stem cell transplantation. Now, if I have to review something, so today let us just only have the time to discuss the immune checkpoint inhibitors and how we can have the T cell activation to deliver immunotherapy in lymphoma. Now, these are the different inhibitory receptors and the activating receptors. And in coming time, we are going to see antibodies, monoclonal antibodies activating these receptors or inhibiting these receptors. And for today's discussion, let us just stick to PD-1, PD-L1, because this is what we are clinically using. So I'll stick my discussion to this. So looking at the immune checkpoint inhibitors in Hodgkin's lymphoma. So in Hodgkin's lymphoma, the story started in 2008 with the finding that there is increased PD-L1 and PD-L2 expression in Hodgkin's lymphoma, which was detected on flow cytometry, as well as it was found to be expressed on immunohistochemistry. And this was found to be expressed irrespective whether Epstein-Barr virus was positive or negative. And then they could link this PD-L1 expression to the chromosome 9p amplification, which was found. And we can see that this was also found in other types of lymphomas where there is chromosome 9p amplification, like the mediastinal large B-cell lymphomas. But in DLBC as other lymphomas, this PD-L1 copy number was not high, so they were not found largely to express PD-L1. Now, the Hodgkin's lymphoma Reed-Sternberg cells classically express high levels of PD-L1. They have a tumor microenvironment which is very immunogenic, and the question remained whether these will be possible to be harnessed by the PD-1 inhibitors. So these were the first phase 1 studies on pembrolizumab and nivolumab, and we can clearly see that in relapsed refractory Hodgkin's lymphomas which were multiply treated even with brentuximab vedotin, so we could see that treatment with nivolumab or pembrolizumab could produce a very remarkable 70-80% response rates with even 20% near CR rates. Now this led to phase 2 registration studies. So this is the phase 2 Checkmate 205 study where they looked at the role of nivolumab monotherapy in relapsed refractory Hodgkin's lymphoma in different cohorts. So the cohort A was naive of brentuximab. Cohort B, they were exposed to brentuximab and also autologous stem cell transplant, whereas cohort C was brentuximab either before or after autologous transplant. And this is the pembrolizumab Keynote 087 study. So here too, the single agent pembrolizumab was used in relapsed refractory Hodgkin's lymphoma in different cohorts. Cohort 1 was the subset which had progressed after transplant as well as subsequent brentuximab. Cohort 2 had those who had failed salvage chemotherapy and were ineligible for transplant or had failed brentuximab therapy, as well as cohort 3 was that who had failed autologous transplant and was not treated with brentuximab post-transplant. So in all these resistant cohorts of relapsed refractory Hodgkin's, so we can see that pembrolizumab here also achieved almost 70% response rates with nearly 20% CR rates, and the similar were the results with nivolumab in the subset where it was exposed post-transplant as well as post-brentuximab. And if you look at the subset which was post-transplant but without brentuximab, here also very similar results, almost 70% response rates with 20% CR rates. Now, one thing which is very different from brentuximab that we see with immunotherapy. So what we can see here is that there is a tail to the survival curves. So if you have exposed these patients to brentuximab and they have complete response, so these patients sometimes go on to have a higher PFS and sort of a stable tail. But in brentuximab, if the patients have partial response or stable disease, eventually 4 to 5 months they are progressing and the curve falls down. Now this is something very different that we see in immunotherapy, that once they are exposed to immunotherapy, even though they are CR or whether they are PR or whether they are having stable disease, there is a subset of patients which will continue to be in response and not progress. So this is something which is very different in immunotherapy. And of course, the patients who have CR have a higher rate of response, higher progression-free survival as compared to those patients who have partial response as compared to those who had stable disease. Now, this is similar with the pembrolizumab. Also, we can clearly see that patients who had CR had a higher median PFS of 33 months, and PR, they had a median PFS of 22 months, whereas the all-comers had a median PFS of 13 months. And if we look at the survival curve, so all these patients were seen to have a long survival. So even though in lymphoma, what I mean to say is that we are always looking for complete responses, complete metabolic responses. But those who are receiving immunotherapy, this is a peculiar thing, that even though they are not having complete responses, and even the partial responders and the stable disease go on to survive long and they don't progress. This is pembrolizumab data, Keynote 051 in pediatrics. So this was again a large cohort of patients where they had included all sorts of diseases, including solid tumors and lymphomas. And it was a phase 1 dose limiting and a pharmacokinetic study followed by an efficacy study. And in this study, what they could say that most of the tumor types didn't have very encouraging results. But in Hodgkin's lymphoma, we can see on the left side 60% response rate with the 80% disease control rates. So again, very durable responses up to 17 months. So good results in the relapsed refractory Hodgkin's lymphoma, even in the pediatric population. These are the waterfall plots, and you can see that almost all the patients had some response. Again, this is only phase 3 study that is available, which is Keynote 204, pembrolizumab versus brentuximab in relapsed refractory Hodgkin's lymphoma. So in this study, they compared 1:1 pembrolizumab versus brentuximab. This was published last year. All the patients had relapsed refractory Hodgkin's lymphoma post autologous stem cell transplant, or they were ineligible for autologous transplant, had failed first line treatment. And what we can see here is that pembrolizumab had a significantly higher median progression-free survival of 13 months as against to brentuximab of 8 months. So clearly showing that in all the subsets, the data was favoring pembrolizumab. And if you look at the response rates, again, pembrolizumab showing a higher response rate of 65% as against 54% with brentuximab. And the median duration of response, again, 20 months with pembrolizumab as against 13 months in brentuximab. So pembrolizumab clearly winning over brentuximab. Again, combination nivolumab and brentuximab is also being evaluated as a salvage treatment prior to transplant in relapsed or refractory Hodgkin's lymphoma. So what we could find here was that the complete responses were increased, as opposed to single agent brentuximab or single agent nivolumab. So 85% objective response rate with almost 63% complete responses. So again, we all discussed the role of PD-1 inhibitors, but again, if we are targeting the PD-L1 ligand in Hodgkin's lymphoma, will it be effective? And this is again a phase 1 study on avelumab. And here also we can see similar great results with avelumab also. Again, exploring the same theory that there is high expression of PD-1 and PD-L1 in the Hodgkin's lymphoma tumor microenvironment. And even with PD-L1 blockers, we can explore this. Again, combination of pembrolizumab. So we had all seen the immune checkpoint inhibitors being explored in relapsed and refractory setting. Now, this is the study in the first line setting with chemotherapy. So pembrolizumab in this patient, this was a single arm study where patients were given 3 doses of pembrolizumab followed by an interim PET, which is followed by 2 cycles of AVD. And then, further AVD, either 2 to 4 cycles in the early unfavorable subset or 4 cycles in the advanced subset, followed by an end of treatment PET. So all the patients were, either early unfavorable Hodgkin's lymphoma or advanced Hodgkin's lymphoma. And this is the remarkable results that you see. So all 37% patients achieved CMR only with pembrolizumab. And after 2 cycles of AVD, 100% patients had sustained CMR. So 100% CMR in advanced Hodgkin's lymphoma is a remarkable result, which is not even achieved with escalated BECOP. So, a great result. And similarly, Checkmate 205 also explored the nivolumab monotherapy followed by combination with AVD. And here also we can see that the end of therapy almost 80% CMRs in this population. Coming to the toxicities in lymphoma. So again, there are no different toxicities of these checkpoint inhibitors as against the solid tumors. But one thing that I would want to point out is more neutropenias that you are going to see. This is because of the immune cells, are itself involved. So that is the reason why you get more neutropenias in lymphomas, but you don't get this neutropenia in solid tumors when you are treating with immune checkpoint inhibitors. If you're talking about other lymphomas, so again, the data is not really good for other lymphomas. The data for other large B lymphomas was not very good, except the primary mediastinal B-cell lymphomas, where you got around 40 to 45% response rates. Follicular lymphoma, again, there were some studies where in combination they were able to get 40% response rates. In chronic lymphocytic leukemia, where there was 0% response rate, but the transformed ones where they had Richter syndrome, there the results were good with some studies showing 20 to 40% response rates. Also, other lymphomas where they think that probably the immunotherapy is going to work are the ones which are virus related or EBV related because of the immunogenic profile there. CNS lymphomas, testicular lymphomas, and the PMBCL. So this table in short represents the results of so far studies on immune checkpoint inhibitors in other lymphomas other than Hodgkin's lymphoma. And we can see that in some of the lymphomas, we have some good response rates. However, the results haven't been as encouraging as in Hodgkin's. Now, just last 2-3 slides on certain peculiarities that we see in immunotherapy in lymphoma. So in lymphoma, we always go for PET CT scan to look at the complete metabolic response, but we must remember that there is an immune infiltration in lymphoma, in lymphoma when we go for immunotherapy, and this immune infiltration may not result in complete metabolic response. So what we see is more of partial responses, less CMRs, but these are sustained responses with prolonged PFS and OS. So always look out for some immune infiltration which may not be causing a complete metabolic response in PET scan. Another immunotherapy peculiarity is an unsuitable combination with immunomodulators. So they tried combining pembrolizumab with lenalidomide in myeloma, and there was severe toxicity and death. So this combination is being explored in lymphoma. We don't know whether this result is going to be there in lymphoma, but this is a risky combination that we should remember. ATLL, again, immunotherapy was tried in adult T-cell leukemia lymphoma, and all 3 patients in the study had hyperprogression and the trial was stopped. So this is there can be peculiar types of lymphoma which have hyperprogression on immunotherapy. And patients who go on to have allogeneic hematopoietic stem cell transplantation post immunotherapy, so they are going to have a high rate of transplant related complications such as hyperacute graft versus host disease, severe graft versus host disease, steroid requiring febrile syndromes, veno-occlusive syndromes, and other immune related adverse reactions. And conversely, there are even reports of acute GVHD developing again when these patients relapse post allogenic transplant and they are treated with immunotherapy. So this is another peculiarity. So this is my last slide. This is a short overview of immunotherapy in lymphoma, and we really see that it is an ongoing evolution, or rather a revolution. So thank you for patient listening.
Thank you, Vivek, for doing justice to a very difficult topic. I think you nicely gave us an update about immunotherapy in lymphoma, specifically on the PD-1 inhibitors. We'll finish the next talk and then see if we can have maybe 1 or 2 questions. I'd like to now invite Dr. Nataraj, who's a senior consultant hematologist at the Mazumdar Shaw Medical Center from Bangalore. Nataraj will talk to us about immunotherapy in myeloma. Nataraj?
Sir, request you to unmute your mic, sir.
Nataraj, you need to unmute.
Yes, sir. Can you hear me, sir?
Yes, sir, we can hear you, sir.
Okay, good evening, everybody. Thank you for giving me an opportunity to speak, to share whatever the little bit knowledge I have with
Sir,
esteemed
sorry
colleagues.
to interrupt you, sir. So your screen has been unshared. So can you share your screen again, sir?
Yes, I'm sorry. Can you see it?
Yes, sir. We
Hello?
can see the screen, sir. Please go ahead.
Okay. Thank you for giving me an opportunity. And after listening to talks by Dr. Siddhartha Mukherjee, who is a great storyteller and also is a feast to listen, and after listening to immunotherapy talks from Dr. Sunil and then, Dr. Agarwala, but I will not go in depth and I will not take too much of time. So we know that immunity can happen from multiple, immune kill will happen from multiple routes. One of the commonest route is the antibody route, and second is the T cell route, and the third one is other dendritic cells and then innate immunity route. So all these things can be exploited. All the routes of your natural immunity can be exploited to kill the cancer cell. So this is the 5-year survival of myeloma patients from 1960 till today. So with the addition of every new drug, the 5-year survivals have gone up. So which was about 5% in 1960s, it reached 25% with the invention of autologous transplant, and reached 35% with the with thalidomide and lenalidomide, and reached for 55% with monoclonal antibodies, mainly daratumumab, and probably it is about 72% with the invention of antibody drug conjugates and chimeric CAR therapies. So what we have to understand in myeloma is an incurable disease. So it is like hypertension. So our aim is to control the myeloma as long as possible, so that their lifespan is not compromised. So the first and foremost immunotherapy or immunomodulatory drug used in myeloma is any of the imides, thalidomide, lenalidomide, or any of the imides. Basically, these things will make the natural immunity to become a little bit more active. Basically, it will increase the production, activation of T cells because of increased IL-2 and interferon gamma, ultimately resulting in cell kill. Also, it will activate NK cells, so ultimately leading to cell kill. And with all these things, it will also activate innate immunity through monocytes, so which will increase further cell kill of these plasma cells. I'll not go in depth about everything. So this is the first drug which is used in myeloma with sort of an immunotherapy potential. The next bodies, this is just like rituximab, which is used like daratumumab, elotuzumab, and cetuximab. So each one has got some advantages over the other one. But the one which is currently clinically we use in our clinical practice is daratumumab, and it's also made by Johnson, and it's still in patent, so it's very expensive drug. So the daratumumab basically kills myeloma cells through multiple routes. It basically binds to myeloma cells, and then it will find one of the antigen presenting cells, and then it will catch those cells, and then it will make the other cells to kill. Basically, either it kills through CDC, that is complement mediated toxicity, or ADCC or ADCP or apoptosis, whatever, and then it can also kill directly also myeloma cells. So it also has some immunomodulatory activities, which are the reasons for deep and durable responses. Basically, it modulates the tumor microenvironment by clonally expanding the cytotoxic T cells, and also they increase the helper T cells. So, and also there are basically, as it affects CD38 is also present on immunosuppressive cells in the body. So those also will get killed. So automatically the immune milieu will become more towards immune activity than immune tolerance. So ultimately leading to myeloma cell kill. So these are the multiple trials which are done. I will not go in depth to every trial, which is I don't think which is out of our time and then out of our area of our discussion today. But whether it is used as monotherapy, whether it is used as the combination, the outcomes are good. So means basically if you use combination therapy, the 30-month survivals are about PFS is about 70 versus 55%, 30-month survival, and 12 months is about 60 and 26.9%. So overall, what I can tell you with this busy slide is whether you combine with any of the drugs, daratumumab with Velcade and dexamethasone, and daratumumab with Pomdex, that is low dose Dex, and whatever you combine, I think overall outcomes are good. These are the group of population who are relapse refractory. But if you use in first relapse, the outcomes are even better than this. The second drug which is used is elotuzumab. Basically, this is an antibody against SLAMF7 protein, which is present on the malignant plasma cells. This drug has been clearly shown to be not effective as a single agent. So it has to be used in combination. And the studies which are tried are with lenalidomide, dexamethasone, or pomalidomide, are lenalidomide and Velcade and dexamethasone. And among all the things, there's good amount of long-term progression-free survival of about at 1 year is about 79% with ERD and 19.4% with plain RD. So overall, the outcomes are good with elotuzumab only when it is used in combination, but it is not available in India at this point of time. The next drug is isatuximab. This also is not available in India. It's basically a little bit stronger than daratumumab, and it kills the myeloma cells even with a little bit more immunomodulation by inhibiting T-red cells. So ultimately, even isatuximab also is used in combination. Single agent isatuximab is not used, and whatever the trials which have been the data which is there, almost doubling of PFS and doubling of OS is there with by using this drug. And mind you, all these fellows are all at least 2 lines to 3 lines they have received. So by then we all know that responses are very, very poor even with myeloma patients. So the next group of drugs which are there are, after we know that just we send the soldiers to kill the myeloma cells in the army when they don't kill enough of terrorists. So terrorists, I mean the plasma cells. Here we also add one payload, that is put one bomb in the back of the robot and then send it to the opposite, sent to the war. So basically, cytotoxic payload is added. The commonest drug which is used and which is approved at this point of time is belantamab, made by GSK. So basically, what it does is it is got the drug conjugate antibody has got a FAB area. So which is this the one which goes and binds to the tumor target. Here it is BCMA, and then it will have a cytotoxic payload. This is the chemotherapy which is attached to this monoclonal antibody. So here with belantamab is MMAF. This is a highly potent auristatin killer, cell killer. Basically, it's like a very potent chemotherapy. If you give just like that, they will die with this chemotherapy. So when you add it to the antibody, so it does a wonder job. Basically, it goes and targets perfectly. It's like a drone going and killing the cancer cells. And so the outcomes of the results, basically the studies which are done using this drug are called DREAM studies. So DREAM 1, 2, 3, 4, 5, 6 are there. DREAM 1 and 2 are published. So based on these 2 data, FDA has approved. Overall response rates, mind you, all these patients are all at least 3-line resistant. Overall response rates are 60% with 3.4 milligram Q3 weeks, and duration of response is about 14 months. So the overall response rate is 38.5% in triple class refractory. That is, the refractory to PI, IMiD, and also even the refractory to daratumumab. So this is a very good data with the current scenario, because we don't have any other drugs which are available in this for this group of patients. So now currently it is used in 2.5 milligram per kg every 3 weekly once, because the next study DREAM 2 showed that 2.5 does better, as good a job as 3.4. So the next ones are, we know that we have sent the payload, but even with the payload, if it is not getting killed, the cancer cells, that means that there's somebody from the inside who is helping these cancer cells. So we have to kill the insiders. The insiders are the tumor suppressor cells. So which are the tumor suppressor cells? Basically the cancer cells will send some signals to NK cell and then the dendritic cells and the other cell killers. T cell or dendritic cells or NK cells to kill these cancer cells. So we give either pembrolizumab or nivolumab or any other drugs. So mainly the drugs which are studied are pembrolizumab. Single agent is not at all effective, but when you add with IMiDs, though the action is synergistic in the lab, but studies were halted because there was increased incidence of immune-related adverse events, and also there was increased incidence of death. So the FDA put a full stop to these studies, and then they have to return with some other different way of studying these drugs. So at this point of time, giving these drugs is not at all right in myeloma patients. So the next one is bispecific antibodies. Basically, when you know 2 people are not getting well along, so you marry them so that they'll stick together and stay together. So this is a plasma cell and T lymphocyte. So you find one linker that is called as a Bhat antibodies. So like a blinatumomab. So the commonest target antigen is BCMA. So the BCMA is one side, this antibody will have one side BCMA and the other side CD3. So basically, once it bites with the BCMA, it will attract the T cells to come nearby, and then it basically makes the plasma cell meet with the T cell, and then T cells will ultimately kill these plasma cells and leading to cancer control. So these are different ways of bites which are produced. One is this kind of a bite where both sides of the drug, both sides of the antibody, heavy chain has got light chains, and the other one is one arm has got one target, the other arm has got CD3, and then there are different. Means basically there are different ways of making these kind of bite antibodies. And the commonest targets which are tried with bite antibodies are BCMA, CD38, CD138, 319, and there are other things. The commonest, as we have to remember, is BCMA and CD38, and the study results have been good in this. With the drug probably which will get approved first is AMG 420. This is from Amgen. It's a bispecific antibody. At least minimum 3.5 lines. Basically, probably patients received anywhere between 3 to 7 lines of chemotherapy, but different lines of chemotherapies for myeloma in the study. Overall response rates are about 70%, 31%, and then median progression-free survivals have not reached in the study. And then though there were about cytokine release syndromes which happened in about 38% of patients which are higher grade. So this drug needs a little bit more fine-tuning, I think, which will happen over coming trials. And these are the other drugs which are going on, other bites which are going on in myeloma, and the studies are expected in this year end in ASH conference or in coming 1 or 2 years. So there's other way of looking at myeloma is targeting. If there is any mutation, target those kind of mutations. So the commonest ones which are tried are, along with ixazomib, pomalidomide, and dexamethasone, either one of these drugs are added depending on the type of mutation they have got. If the CDK2, abimaciclib, and then IDH2, enacetinib. So these are the drugs which are being added. The study results are not yet out. Results are expected to be available in about coming 1 to 2 years. So this will be a very interesting study to look forward and then see how we can improve the drug therapy in myeloma. CAR-T therapy, I will not go in depth with CAR-T therapy, as Dr. Siddhartha has already covered in depth about CAR-T therapy. So these are the different targets which are tried. The commonest target which is tried is BCMA, followed by CD38 and CD138, and then kappa light chain is which is tried. And these are the different studies which are going on. If you see, the commonest one is BCMA from top to down in this list. So BCMA is the commonest one. And then overall response rates are very, very good in these studies. Approximately about 75 to 80% overall response rates. The most important thing we have to see in this whole slide is number of previous lines of treatment. In this first study, 10 previous lines, 6, 4, 9, 7. So after this many studies, if there is any therapy which is giving this at least 70% response, overall response rates, I think it is like a wonder drug or sort of a magic bullet which has come down from heaven for myeloma patients. So this is the pooled analysis from different studies, from anti-BCMA studies. Overall response rate is about 84% and CR rates are about 43%. MRD negativity in this CR who achieve CR is about 83%. And this kind of depth of response is unheard of with any of the drugs which are available in myeloma, even sometimes in front line. So even in second line, we cannot achieve this. And this has been achieved in patients who have received 8 to 9 lines of therapies. And even CAR T cells fail at some point of time because of quality of like altered quality of the T cells, and then off-tumor toxicity and non-tumor toxicity, antigen escapes, and soluble proteins. There are solutions for each problem, but we don't know yet which is the best way to go ahead. And so other way of looking at is why can't we do a combination like how we do combination chemotherapy? Why can't we do a combo CAR? So there are different ways of combo CARs are tried. One is 2 different CARs are co-administered, BCMA and CD19 CARs are co-administered, and tandem CARs are co-administered. That is 2 antigens specific sites on the single CAR, and then bicistronic CARs are there. That is 2 different antigens are there in two CARs given in a single cell. So all these are all tried, and the trials outcome, the studies results have been good, but these studies are very, very premature in less than in sort of phase 1 trial. So the combo CARs, which are like if you see overall response rates are 95% and then 83%, 100% in few patients and 88%. So these are all, remind you, patients who have received more than 4 or 5 lines of chemotherapy. So this kind of results, I don't think anybody can achieve with any current available therapy. So for each one, what is the pros and cons? As we know, the antibody drug conjugates are bispecific antibodies. They are all off-the-shelf products, very easy to obtain and then give to patient. But CAR-Ts have got very high response in relapsed refractory setting, which is not seen in any of these two. So other advantages, antibody drug conjugates and bispecific antibodies, we can get it as and when we need it. Here, you'll have to make it and prepare it, so it's going to take a lot of time, at least 3 to 4 weeks. But myeloma gives this much amount of time, unlike leukemia, so we can still negate that debate. The con is important con for every line of therapy is very, very expensive and it's very costly. For the drugs, it is continuous therapy, but for CAR-T, it is production time. But CAR-T is a single one-to-one treatment or probably twice treatment. So it has got some advantages. So overall, probably if the way the future looks is they're going to be it's going to be mainly CARs over the next coming decades. Probably CARs will come up the second line or even maybe front line in coming 4 or 5 years. So at this point of time, what we know in myeloma is we know that there are different things which will work, but all of us are blind how to combine them, or which is the first one to use, or which is the best way to go ahead. So with this, I will conclude my talk. And then again, I thank for the opportunity which is provided to me to share whatever little bit I know. Thank you so much.
Thank you, Nataraj, for giving us a nice little overview in myeloma on the importance of immunotherapy and the newer drugs which are actually available and kind of accessible, I think, for most of us now. I think there are 1 or 2 questions which are there, which I'll finish off before we go to the panel discussion, which is the last part. I'll start with a question to Dr. Sunil. This is from Ruchira, who's asking that if a patient becomes MRD negative with the first dose of 0.8 per meter squared of the inotuzumab, would you still want to give the remaining 2 doses, or would you just take for transplant straight away?
So if it has to be answered, a very tricky question. If it has to be answered based on data, I don't think we have data. But if we answer this on merits of logic, it should be enough, because ultimately our aim of treatment, whatever it is to get them in MRD negative and transplant, because outcomes of transplant are of course going to be better if MRD negative status is achieved. So in a practical world, I would say that should be enough, because we have got the patient MRD negative state. But I don't think I will have a data to support that. We have data on MRD negativity and transplant outcomes, so we don't have data if someone on target therapy has received XYZ doses and got MRD negative. Would that transplant outcome be different? We don't have that data. But in the practical world, I think I will go ahead with the transplant straight away once MRD negative is achieved.
Right, fair enough. Next question to Vivek or even Nataraj. What is your opinion on doing a genetic test to the patient before deciding on the treatment? So either Vivek or Nataraj can take that. Are either of them there?
Yes, sir, I'm here.
Okay. Nataraj, your thoughts on that?
Sir, I think once somebody is in relapsed refractory setting or even frontline, I will discuss about myeloma because it was the talk of mine. I think we all should do FISH, and then we should see who will respond to which drugs. So, and also whether 17p deletion is there in myeloma patients, because we can prognosticate the patients in a better way. And as I showed in one of my slides, currently a study is going on with whichever the point mutations are there. Depending on that, can we choose the drugs, and then can we see a better outcome in patients? Ixazomib, pomalidomide with dexamethasone, and along with different drugs are there. For example, IDH2, if there's a mutation, inacitinib is added. So the study data is not yet out. So we do not have clear-cut data to use currently the gene mutations for choosing the drug in myeloma.
I think just across the board, I think most of us are testing, at baseline to trying to either to prognosticate or try and pick drugs which you can specifically use in a subset of disease, either as an add-on or subsequently in maintenance. So I think that's already happening. More and more of the data is being incorporated into individual patient therapy as we get more and more personalized towards care for the individual patients. Okay, I think those are the two questions which were pending. Now we'll go on to the panel discussion where we'll again come back to the first topic of CAR-T in India. And I'm delighted to have a very elite panel here. The first of whom is Dr. Anil Kamath, who's the head of clinical development at Immunotherapy. We have Dr. Arun Anand, who's the CEO of Immunotherapeutics. We also have Dr. Sarita Jaiswal, who's program director of the BMT unit there and at Dharamshila Narayana Super Specialty Hospital in Delhi. So we've got a hardcore clinician. We've got Anil, who's done clinical work and moved on to the development part of it. And Arun, who's experienced in molecular biology and heading the Immunil is there. So we have a mix of talent there. I'll just go on to the panel discussion presentation. And we will just project that. Just give me a minute. Yeah, so I have some individual questions for each of the panelists. I'll start with the first one to Dr. Sarita. Dr. Sarita, is there a clinical need for CAR-T therapy in India? Your opinion on thoughts on that?
Yeah, hi.
Hi.
Thank you, Dr. Sharat, for asking such a burning question, which is the demand for the current era, I can say. Yes, we have moved forward from bike to car. So this is the only demanding thing from the doctor's point of view, clinician point of view. But at the same time, we have to look from the family or the patient's side of view. So there are multiple caveats, but yes, I would prefer to go for the CAR-T cell therapy in India.
So you clearly think there is a need, which is good to hear, and clearly now we need to look at how it can actually come here. So I'll now go on to the second part to Anil. Anil, from an infrastructure point of view, is this feasible, doable? After hearing Siddhartha, put his thoughts together, your thoughts on this?
Firstly, Sharat, thank you very much for this excellent program, getting together such eminent speakers, and I certainly there's a lot of things to learn too. In terms of infrastructure, it's one of the three pillars, as Sid mentioned in one of his slides, in addition to R&D, which is science, and people, because skills, people, manpower is also a very important point. From the infrastructure perspective, there are various challenges. And as you know, you have the manufacturing bit, which is GMP suite. It could be an open system, a semi-integrated system, or a closed system. And there are various options which individual or each group has to look at what is most convenient. And then you have the quality control. So from the Immunil's perspective, we look at all these three pillars, which is the people, the science, and the infrastructure. And the aim of Immunil is to bring these treatments at an affordable price. And we have set up, as Sid pointed out, a GMP suite, 3 suites, in fact, to make these products available to India. And the aim is to do it in an affordable way. So the question is very relevant. It is a challenge. It is not that easy, but I'm also aware that various other groups in India are also working on this. So it is a difficult one, but it is something that we have to meet to make our mission to get the CAR-T to Indian patients.
Right. So that's very good to hear that clearly, even though it is difficult, it's certainly doable. And considering the fact that it can be done, I'll now go to Arun to ask him, so if it's possible, what are the regulatory requirements for this kind of therapy to be initiated in India, both from a clinical trial perspective and offering it as a therapeutic strategy?
So thank you very much, Sharat, for inviting me to an excellent presentation round and a lot of learning. So there are a couple of points I want to make. The first one is, unlike usually stem cell therapy, this is not regulated like a therapy. This is regulated like a drug. Mm-hmm. And with it comes all of the bells and whistles that come with drug development, which means you have to follow through with very stringent CMC, very stringent animal model work, very stringent GMP data that facilitates the review of this as a drug. Unlike single window mechanisms that are available in the US and Europe, India does not have a single window clearance system, which means that fundamentally you're actually going through several committees to make this happen, which may include the RCGM committee, which is where all of the CMC data gets regulated. And then you have to make sure that your facility is licensed for a specific product, which also means that both the state and the central FDA have to come and inspect your facility, make sure that you're complying with Schedule M, which is the manufacturing requirements for all sorts of drugs, including pharmaceuticals and biotech. And therein lies the challenge, because in a country like India, where there has been no experience with regulating some products like this, the inspectors who come to visit a therapy, visit a facility which makes a CAR T therapy is going to look at it very similar to what they would look at when they come to visit a small molecule therapy, or when they come to visit a facility which is making biologics. So that differentiation between understanding the nuances of therapy that is required for manufacturing these kinds still is evolving in India. That's the challenge.
Yeah, that's a very important point I think Dr. Arun has brought out, that clearly there aren't clear defined regulatory requirements. Some of it has to be kind of now put into place as some of this is actually getting available in our country. So I think that was very nicely put. I'll go on to my next set of questions. Sorry for this, 1 minute. Yeah. So the next question is to Dr. Sarita. So Dr. Sarita, what are the disease subsets where you think CAR T would be most useful to patients in our country at this point in time?
Yeah, looking into the data, we think of B-cell malignancies like leukemia, lymphoma, and at the same time myeloma also. Our data in AML, we have still got this adaptive immunotherapy on NK cell-based immunotherapy, and we have excellent results as compared to that. So I would prefer these B-cell malignancy for the CAR T cells.
Okay, right. So that's a nice point you've raised about the, having adoptive NK cell-based therapy, I think, for the AMLs. There's good data from your center. So that's interesting to hear. So clearly, there is a need in at least the lymphoid malignancies and myeloma for sure. But I'm sure there will be something more coming up in the AML area also, like what Siddhartha had mentioned, where we kind of include that will be something which we can debate on later. So considering that, that need is there, and clearly you got this from the clinical point. So I'll go to Anil and ask, so if the requirement is there, which are the diseases which you think you can provide at the earliest some form of therapy?
Right, Sharat, as you put it in this program, what we heard from Sid and all the eminent speakers, we have covered the three most important hemato-oncology diseases. And we look at the US FDA approved drugs, they are all in ALL and BNHL, all the 4 approved drugs. So I would foresee that the 3 primary diseases that we would focus on will be acute lymphoblastic leukemia, B non-Hodgkin's lymphoma, and multiple myeloma. And I think those are the 3 areas that we can serve based on the data that is available. And moving on then to solid tumor. Solid tumor is a more difficult area because of the tumor microenvironment. It is a bit more complex, but I'm sure we'll get there. But those are the 3 top diseases. And I think you heard from the speakers, Sid, and all the others, how this can be a very useful option. And if given earlier point, I mean, I'm not looking at second or third relapse. I'm looking at earlier on, maybe after first relapse, or maybe as a consolidation. And those are the challenges that we need to look at. And if you could provide this affordably, I think the treatment algorithms in this country will change.
Yeah, absolutely fair. Fully agree with what you've said. Clearly, affordability is the issue which we'll need to look at. But I'm thinking there is a subset which can, certainly look at affording this kind of treatment. We'll go on to the next part. That is a question to Dr. Arun. So clearly, if you want to bring this in, I'm sure initially you would have to look at conducting some kind of trial first and then demonstrating safety and efficacy. So what do you think would be the challenges for us in our country, Dr. Arun?
This is a very, very critical question, because I think all therapies start at clinical trials before they become real. There are 3 things which I think we should consider. The first one is, while we have a clinical subset or clinician subset second to none globally, there's a relative lack of experience related to first-in-human studies in India. which means that for something as pivotal as a CAR T, where the product is defined by the process by which it's manufactured, almost every clinical trial will need to have that experimental basis before they get more comfortable with the kind of side effects and the kind of adverse events. Second point, a lot of Indian immunome, if I can use that word, is relatively unknown, which means that many patients in India, we don't really know how they would react, what their T cell repertoire would look like when they react to certain investigative agents like this. I mean, for a case in point, the reason why we are having lower mortality with COVID is still befuddling many people. And most of the patients in the US and in Europe who've received CAR T therapies have really received it after 5-7 lines of therapy. So if we were to do a trial like this in India, most of the patients will have to be either first line relapse or second line, which means that their immune repertoire is a lot more preserved than patients who've gone through multiple lines. That's a second or third challenge which physicians and clinicians doing clinical development for CAR Ts have to keep in mind. And lastly, the question does remain on cost. Indian regulators and also clinicians expect large volume body of data before we can consider anything as experiential. If we were to do a 100-patient study for CAR T, it's going to burn the bank everywhere. So you just can't afford to do as large clinical trials as you're typically accustomed to for biologic therapies. So understanding the rationale for why single trial or single agent studies or single arm studies are done in the sense of CAR Ts is a very important paradigm shift that is necessary to understand the utility of these kinds of therapies in terminally ill patients.
Right. Thank you, Arun, for giving us a lot of clarity on that. I'll go on to the next set. So, Dr. Sarita, at what pricing do you think CAR T would be an option, considering the fact that, we are kind of going to compare this to an allogenic transplant, which could be even a haplo or a MUD, when you're bringing this kind of option to the patient. So what do you think is kind of reasonable from a price perspective where we think that it will be truly affordable to our subset of patients?
It's a very difficult to answer because, yes, I don't want to reduce too much because every experiment, like everything, cost. Right. If you make it too much reduced, then of course the quality will be compromised. So I don't want to be reduced price, but yes, it should not be like 2-3 CR as it is in the US. So of course 1/4 price reduction is needed in India, I think so.
Yeah, I think that's a very fair answer, I think, from Dr. Sarita. And I think that's the feedback we would also like to convey to Emmanuel. I think from the clinician perspective, if you can bring it to 20-25% of what it is in the US, would be a big, would be a nice start at least, So that's a nice thought. So we'll go to Dr. Anil. Dr. Anil, do you think centers in India would be able to handle CAR T therapy, considering the fact, CRS is a known complication, you need backup systems for that. So what are your thoughts on this, having worked on both sides?
Yeah, Sharat, it's a very valid question. But obviously, when you introduce a new technology, there's always a steep learning curve. And in this, most important is the ecosystem in training and education. And when you hold the hand in terms of the first few patients, and we see that the patient can do well, I think that adds to the confidence of the treating team. So I think initially, of course, it would probably be appropriate to limit to a single center, but I would expect this across the country over a period of time. And also another bit would be, as Sid referred to, is rather than bringing patient to the treatment, we can get the treatment to the patient. So in terms of handling CAR, I think it is not, it is doable, but it does require a planned approach, a good learning and educational program. And I think it is likely that Indians and Indian patients will get benefit, and our clinicians will be very comfortable. It is not going to be, it's not going to happen overnight. It's going to be a learning curve. But I think the 3 A's, access, available, and affordable, would define this happening. And I think it is going to happen. Yes.
Yeah, it's good to hear that this is certainly doable in India, with currently the number of transplant centers close to about 100 now in the country.
Yeah, absolutely.
I think certainly it is doable. Now, clearly, I must give the tough question to Arun. By what mechanism would you make this therapy affordable to us in all the centers in India?
This is by far the toughest question. I know that. So let me sort of warrant a guess. Couple of things. To Sarita's point, I certainly think that it's something that a company like Immunil, which is focused on responsible access to patients in this specific niche segment, we should be certainly looking at that kind of a ballpark to start off. But here, I think short of allogeneic, if we're still relying on the autologous therapies in this space, we'll have to look at one or two mechanisms that have not been fully studied so far. One is how much can the government support in critical care like this nature, because these are not going to be used for patients who have alternative therapies available. They're going to be used for terminally ill patients for whom this can be a tremendous boost. And second, we have to consider moving on to other kinds of financial metrics apart from immediately paying everything up front, which is the traditional way India has held medicine because of our significant out-of-pocket market. But if we look at microfinance, pay-as-you-go, success payment, those are different kinds of mechanisms that the West have adapted for innovative therapies to ensure that not just patients have a staged way of paying for therapies, but also payers are able to cover for insurance based on success.
Right. Thank you, Arun, for giving us that feedback. My last set of questions. So first one to Dr. Sarita. Where will you position CAR-T in the scenario of an allo transplant in a relapse setting at this point in time?
Yeah, if you look into the data which is on the CAR-T, it is very limited, and we don't know the long-term complications and outcome. Now, we are comparing this with a 50 years experience of an allogenic transplantation, and where we have upfront the data on haploidentical transplantation in some of the diseases are excellent. Where our center, we have used the CTLA-4 IG along with donor lymphocyte infusion, which gave us an excellent result, which is comparable with abroad also. So yes, we have to, it is not be all and end all CAR-T, but we have to do CAR-T as well in the diseases, particularly which are really refractory and the relapse cases. So in that setting, I would prefer, otherwise we have to see how we can fill up these caveats for CAR-T and take it on upfront.
Yeah, I think we have to look back and look at comparative data, like what you mentioned, there is 40, 50-year data on the allo. But then clearly we also have relapses post-allo, you want to bridge to allo. So there are various other situations where I think, we will have a need for something more than just the standard allo. So I think it's certainly something which is food for thought. So to Dr. Anil, is there a role for CAR-T thereby upfront in higher risk diseases? Is that a thought which you would like to consider?
Sharat, a very valid question, especially from the Indian perspective. As we are all aware, the 4 approved treatments in US, Europe are in ALL and BNHL in second line relapse refractory setting. Having said that, we already have trials in a high risk setting. So it is already happening in the West. And if you extrapolate the data from the BiTEs, that is blinatumomab, which has been used in this setting that you are referring to in ALL, and the Dasasion study, which was in a Philadelphia positive ALL. And if you also look at blinatumomab as a consolidation for high-risk ALL, and the data was presented in ASH. So you could see that the proof of concepts for bispecific is already there. And we'll get some more data from US in high-risk disease. And the wonderful thing about this is the patients in India will be most at benefit. I mean, as you know, the standard treatment for ALL is 2 years of maintenance for girls and 3 years for boys and males in the absence of allogenic transplant. And if you could reduce this to, let's say, a short induction only with steroids and maybe some CNS prophylaxis, which is what the Dasasion study did, 4 to 6 weeks, followed by a CD19 CAR. And if you, and that's it really. I mean, you can reduce the treatment duration from what is a 2 to 3 year treatment to potentially 8 weeks or 10 weeks treatment. And I think that's phenomenally great, because that is good for the patient. It reduces the toxicity, it improves the quality of life, and on the long term, it is cost saving. And I think the biggest potential will be in India, and not just in ALL. And we know this from B non-Hodgkin's lymphoma, the primary refractory patients. None of the available treatments work well. And same thing will happen with multiple myeloma. Rather than waiting for second, third, and fourth line relapses. So I agree with you, Sharat, that I find that CAR T eventually will get there, but the proof of concept is we have to make sure we get comfortable, our clinicians are happy, the patients are comfortable, and we'll eventually see that in that particular position.
Yeah, certainly nice thought, Anil, and I think similar to what Siddhartha had also echoed right at the beginning of this session, that it's a nice thought to actually consider it upfront rather than wait for multiple relapses when, you know, the outcomes are also going to be that much worse off.
Thank you, sir.
Coming to the last question directed to Arun, the clincher question, when will Emmanuel be able to provide CAR T therapy in India?
Thanks, Sharat. Sooner than later is a generic question, a generic answer. But we have licensed in our first CD19. It's in the public domain. This is a product that has gone through very good clinical data in Spain, and we are working very hard, working through regulations, working through the regulatory process to get the first clinical trial started, all fingers crossed, in 2021.
Right. Okay. Thank you. So on that note, we'll end this little webinar. I think we've had a nice session with good talks and a lot of discussion. I'd like to thank all the speakers and the panelists for your time and your effort to attend this meeting and make it a really wonderful session. Thank you all the delegates who've attended. Thank you, everybody. I think we'll end the session here. Thank you.
Thank you, Sharat.
Thank
Take
you
care.
all.
Have a nice
Thank you, Sharat.
Bye. 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 Bye.